Hello, everyone. Welcome to the Aesthetic Mentor. 7 o'clock Tuesday. I'm here for you every week. I've got an interesting sort of show tonight. I think you might find it very interesting. I'm going to talk a little bit about biostimulators versus fillers, but I also want to talk about an experience I had last night. Dr. Stephen Yolen from San Diego, who's a trainer for Allergan, came up. Hello, everyone. Hey, let me know where you guys are from. I always enjoy seeing where you guys are from and whether you're a nurse or an NP or an MD or whatever you are. I'm always interested in hearing that. And, I like to hear where you're from and what you're doing. So feel free to chime in. Hello, the Model Lab just joined. And we've got someone from Dallas. Welcome, y'all. We have someone in our office we call Red. She's got red hair, so we always think of Dallas when we do that. Another nurse practitioner. It seems like we have a lot of nurse practitioners joining, which is great. I'm going to talk a little bit about my experience with Dr. Yolen, who visited my school aesthetic mentor in our Massachusetts location last night. And then some of the conversations we had regarding occlusions and retrobulbar injections and all that sort of stuff. And I want to talk a little bit about this new product that I heard about today that's coming out that I was initially consulted about like over 3 years ago, and interestingly, I think it finally just made it. It's about to make it to the market. Gabalicious, like always, you are here. Deluxe Bar, great going, girls. Good to see you. Hope you're feeling better. Hope your neck's okay. She had a little bit of a rough night with us last night. We didn't do much to her, but she was already in pain when we saw her. So thanks for joining. So, Heather, I'm going to talk a little bit about our experience with Dr. Yolen last night. And you were the one who was asking most of the questions. So I'm going to steal a little bit of your thunder. The Deluxe Bar. Yay. I'm asking people to tell us where they're coming from. Where are you joining from? We usually get people from like Brazil, Spain, Mexico, Canada. It's always fun to hear where you're from. So last night, Dr. Stephen Yolen, who's an ophthalmologist who's been with Allergan, aesthetics for like 15 years. He was the first guy who described the fact that people's eyelashes get longer and thicker when they use Bimatoprost, which you may know now is being sold by Allergan. So he was talking about his experience, and he came to our school because, hello, Christina Med Spa. Hello, Nurse Marissa. Where are you guys from? Let us know. He was talking about, his journey over the past 20 years. He was talking about the state of the art. And one of the people who from Deluxe Med Spa, in Mode Austin, where would we be without in Mode Austin, who joins us every week at about this time. Welcome. So he was talking a little bit about, the developments over the past years. And one of the nurses, actually one of the nurse practitioners, Heather, said, when you were here 2 years ago, you were talking about retrobulbar injections. And she goes, for blindness. And she's like, those words, she goes, I can repeat almost verbatim to you the talk you gave us, because she said it left such an impression upon me, and I'm so frightened. Beverly Hills? Oh no, Beverly, Massachusetts. I thought it was Beverly Hills for a second. Hi, Christina. Good to see you guys again. And she was like, I remember almost verbatim what you said to me about, these retrobulbar hematomas that I've been having. I'm sort of dramatizing a little bit, but these like recurring nightmares and dreams about what can happen when you inject, a gel into a vessel that's, supporting the eye. And we were talking a lot about it, and I'll discuss some of the interesting points that I think came up. But let's talk just for a second about occlusions, because that came up. Hello, Kathy NP, one of my loyal NPs who's always here, always wanting to learn more, always trying to be the best she can be, which I think all of us are hopefully trying to do. Here we are on Tuesday night at 7 o'clock talking about stuff after a long day of work. But where are you guys from? Chime in, let me know where you're calling from or watching me from. So we talked about occlusions, right? And Heather was saying, I'm not even so afraid of occlusions anymore because I know, that the proper protocols and procedures can, kind of result in a salvage and, pretty much avoiding any significant complications. However, the eye is different. Why is it, do you think, that there has never been a case of blindness from a filler that's ever been reversed? Except in a rabbit model, which I can talk about with you as well. But why do you think that no one has ever found a way to reverse blindness, even though they may be really experienced injectors? And this came up last night because Dr. Yolen and I were talking about this in front of the class. Hi, Tracy. Thanks for joining. There were three very prominent physicians in this country who are some of the leaders in aesthetic medicine. One's a plastic surgeon, one's a facial plastic surgeon, ENT doctor, and the other one's a dermatologist, all of whose names you would probably readily recognize, who all had a case of blinding a patient. As I said, some of the most respected people in the industry. So if it can happen to them, why would you think it could happen to you? Right? So we talked a little bit about what happens, injecting into the external carotid circulation, and somehow there's a crossover to the internal carotid circulation, and you get a little bit of product into the ophthalmic artery, and then a branch of that is the central retinal artery. These are small vessels, but that means you don't need much product at all. A little retrograde circulation into that internal carotid circulation up in this area, and you can have blindness. But why is it impossible to reverse? Why hasn't it ever been done? Well, what is the retina, and how is the retina different from any other area where we get an occlusion? We've had, in our network, we've probably had a total of 50 occlusions. Thank God, never one to the eye, because we have certain parameters and protocols in place that make that hard to do in our network, because for the most part we don't allow people to do injections in these areas that we consider very high risk unless you're extremely skilled, and even then it makes me nervous. However, understanding what happens in the retinal circulation versus any other area is important. As I said, we've had 40 to 50 occlusions over the years, and every single one of them has been reversed without any sequelae except two. And the two were largely the result of a significant delay in diagnosis and a significant delay in treatment. We were able to salvage them to some extent, but it took me, 2 years of trying to help these patients, of doing all kinds of things to help them, and they ended up being pretty good. Perhaps you might not be able to tell if you didn't know, but still, it was 2 years of their life and 2 years of my life, and those nurses that treated these patients were devastated and were about to quit. But in any case, I diverged for a second because those situations were all manageable, and if it weren't for those two cases that had a significant delay in diagnosis and treatment, they would have been no significant long-term sequelae. But the opposite is true of the eye, and the reason, can anyone guess it? Can anyone tell me what you think, why the retina is different than every other part of the face that we would inject? We got an anti-aging center there. They might know. Where are you guys from? Anybody from far away? Anybody from a different state or country? Are you an NPMD, RN? What are you? What are you guys doing? The retina is an extension of the brain. How long can your brain go without oxygen? Call me Connecticut.
Connecticut.
Yeah. Gotcha. Connecticut, Massachusetts. How long can your brain go without oxygen? I don't know, 10 minutes, 15 minutes, 12 minutes. The retina is an extension of the brain. So how long can the retina be ischemic? Well, the same as your brain. And I think, once you get past 15 minutes, you're probably cooked and your vision's never coming back. So if you're ever in a situation, Argentina, that's your neck of the woods. Pedro's from Brazil. And so he's here with me every Tuesday. Thank you for joining us from Argentina. We appreciate the support. So because the retina is part of the brain, you've got somewhere between, maybe a maximum of 15 minutes to act. So if you do have a sudden blindness from injecting the temple or the nose or the nasolabial fold or somewhere where those two circulations converge, and you get a bolus into this ophthalmic circulation and perhaps a central retinal artery, you've got 15 minutes to act. So we talked about it. So Dr. Yolen was talking about taking a cannula, a 25 gauge, 1.5 inch cannula, going halfway between the lateral canthus and the mid-pupillary line, making a small poke hole, and then going right with the cannula right along the floor of the orbit, scraping right along it, and then getting into go right up to the hub of the needle, and then inject into that retrobulbar space. And he's, injecting up to 10 cc's of high hyaluronidase. Hey, Carmel, big day tomorrow. Get some sleep tonight. Good to see you. Thanks for supporting us. So he was talking about putting 10 cc's of vitreous into that retrobulbar space and talked all about how to do it. So it was kind of chilling and challenging for the students who were at school last night watching this. But it's kind of like, what other option do you have? It's like seeing someone lying on the ground in cardiopulmonary arrest. Are you just going to walk by or try to find help for someone? Or are you going to start CPR? Because if you don't, the person's going to die. Well, the same thing holds true of blindness in the retina. If you don't do something right away, the patient's already blind, right? That's the reason we're talking about this. If you don't do something, that blindness will be irreversible, and you've only got 15 minutes. So you have to act. You really don't have time to call anybody. You really don't have time to do anything. Time is completely of the essence. So you've got to really work quickly, and you got to know what to do. So we decided, as a result of talking about this and seeing the reaction of the students, that we were going to include this in our cadaver course. So from now on, we're going to have the cadaver head, and we're going to do the dissection on one side to show the how to get into what the retrobulbar space looks like, so you can actually have a visual image in your brain. Then we're going to start doing it in cadaver, sort of poking along the floor of the orbit to get people comfortable. God forbid they should ever have to do this. Hey, Green Rise Homes, our usual Tuesday chat. Thank you guys for joining. Thank you for your support. So you want to have some idea of what you're doing, right? So these cadaver dissections really provide us with another opportunity to teach you something new. And hopefully you'll never have to use it, but if you ever do, it's like, okay, at least I remember somehow how to do this, and perhaps you'll save someone's vision and maybe someone's life. So this is a great thing to know. So that kind of stimulated me thinking. But then, as an additional part of our conversation, we were talking about occlusions in general, and he was talking about these two cases he knows of where there was some sort of occlusion in the mid-face. It might have been a nasolabial fold, it might have been a cheek, it might have been both. And how these two different cases used 19 vials of hyaluronidase to treat the occlusion. Now, I can tell you, after having treated somewhere between 40 and 50 of these, I don't know that we've ever used more than 5, and I think our range is 2 to 5. And almost invariably, when someone gets an occlusion and they bring them in, or they start talking to you over the phone and trying to do some telemedicine, so to speak, the minute you inject your first vial of hyaluronidase, the patient has a subjective sense of it being better. They have much less pain. And you know right away that you're working. You start to look at the tissue. It starts to pink up again. And more than anything, the most important thing you need to know is, what is your endpoint? Like, when do I stop treating? When is it safe for me to stop treating? And it's really always the same. It's when capillary refill turns back to normal, right? So it just shows you that you're being perfused again. Now, that happens right away. And, 1 or 2 vials, it depends, are you using Voluma, are you using Ultra? One that takes, there's a lot more cross-link, so it requires more hyaluronidase. But almost invariably, by 1 or 2 vials, you're better, the patient's better, and you're on your way. If the capillary refill returns to normal, you're done. You don't need to do any more. Certainly not 19. That's an insane amount. Like, why not just hook the person up to an IV and constantly infuse their face with hyaluronidase? I mean, it doesn't make any sense. If the patient subjectively subjectively states that they're feeling better, you can see the blood flow is better, you can test capillary refill. That's another thing. How do you test capillary refill? Do you go like this? No, absolutely not. People were literally asking me this last night. So it just shows me that people are doing a lot of these injections, and we talked about this, Pedro and I. The level of education and aesthetics is, in my mind, pretty poor. But people are saying, well, how do you test capillary refill? If you don't know how to test capillary refill, what are you doing in this field? What are you doing injecting people's faces? What are you doing taking people's lives into your hands? I don't know. So I said, okay, take your finger and put it on the area where you just injected and hold it there pretty hard for 10 seconds and don't let go. And then let go and count how long it takes for the blood to return back into the field, into the tissue. If it's more than 2 seconds, then you have delayed capillary refill. If it's more than 4 or 5, you got to give more product, right? So you give more product, you put it in the area where you've treated the patient, and you flood the area with hyaluronidase. I have never seen anyone not really respond well after just a couple, but hearing these stories about 19 vials being injected makes no sense to me, because once you've established normal capillary refill, what are you doing? Certainly nothing good. The more time you inject, the more times you traumatize the tissue, the more bruising you get, the more swelling you get. You're like working against yourself. You're actually making it harder to tell if your capillary refill has returned to normal. So what that indicated to me is the people who are doing this have no idea what they're doing. They don't understand what, when you have an ischemic area, then you reestablish blood flow, what that looks like. It doesn't turn bright pink in a second. It takes time. Your tissues have been injured. Who knows how long this has been going on? I mean, there have certainly been reports of people having an occlusion for more than 24 hours, maybe even up to 48 hours, and being injected with hyaluronidase and having a great outcome. Again, not the retina, having a great outcome with no long-term sequelae. It can happen. So it kind of shows you that people are panicking, rightfully so in a way, but have knowledge of when you need to panic, right? If the patient initially says, oh my God, that already feels better, you should start feeling better. If you see, oh my God, it's gone from white to slightly pink, you should feel better. And after, half an hour, 20 minutes, you press and you can say, oh my God, the capillary refill has gotten so much better. Maybe it isn't perfect. Maybe I do need a little more, but I definitely 100% don't need 19 more. I mean, that's crazy. So I'm going to do another Instagram Live with another very well-known educator. We're going to talk about a lot of these things, because I think the standard of medical aesthetic education in this country is terrible. I think you guys aren't getting good education. I mean, I'm here to try to provide that for you, but I'm one man fighting against the world. Hi, Mel. We met Mel in class last week. And Mel, good to see you. Thank you for joining. Tell us where you're coming from. Hey, Bree. Bree D's on board. Bree D in the house. You're welcome. I'm glad you love these lectures. It's my passion coming on. I can't stop talking about it. We were talking, Bree D, about Dr. Yolen last night and the retrobulbar injections and why the retina is special, because it's part of the brain and you've only got like 10 minutes to act, or the blindness is irreversible. And then trying to understand, when you do have an occlusion in another part of the face, how to manage that and how to do it successfully. The other thing you should know is you can't hurt anybody with hyaluronidase, but be sensible about it. You're like assaulting the patient, giving them 19 syringes of hyaluronidase. It makes no sense. But read about it, listen to what we're telling you, be smart about it. Thank you, Pam. You're welcome. Do you guys, hey, Lulu, new to the game. Thanks for joining. Hey, Mel. So, any questions about retrobulbar injections, pre-bulbar injections, if you can't reach the post-bulbar space, or occlusions, or comments? I love that you're talking about occlusions. I feel like it's overlooked. It's overlooked because no one wants to talk about it. And you have to know how to handle an occlusion if you're doing an injection. If you don't know how to do it, you really put that patient and yourself and the industry in general in a bad spot. And people always say to me, well, Dr. Russo, you do all these injections. Where's the most dangerous place on the face to inject? My answer is always the same. I never hesitate. It's the area where you don't know the anatomy. If you don't know the anatomy in a certain place, you shouldn't be injecting there. If you don't know how to handle an occlusion, you shouldn't be injecting there. If you don't know how to help do a retrobulbar injection in someone who you just created blindness in, you shouldn't be in that area. You shouldn't be anywhere near the mid portion of the face, the central portion of the face, because that's where most of the blindness occurs, aside from the temple. It is overlooked. What are these complicated patients reporting from? I don't know what that means. Where are these complicated patients reporting from? I don't know what that means. Canary Islands just joined us. We're going worldwide with this stuff. We're talking about blindness from injections in the face, temple, nasolabial nasal bridge, all this sort of stuff. Anywhere where the external carotid circulation can connect with the internal carotid circulation, get into the ophthalmic artery, then the central retinal artery, and then you've got big trouble. So, Claire Bear, a regular on the program, thank you for joining. These reports are coming from lots of places. Obviously, occlusions are underreported, but I was talking about a conversation I had with Dr. Stephen Yolen, who flew out from San Diego to be at our school in Waltham, Massachusetts last night and talked to my higher level providers, my ninja nurses, as I call them. And he was talking about how a very, very prominent plastic surgeon, a very, very prominent head and neck doctor, ENT doc, facial plastic surgeon, and a dermatologist, who are leaders in the industry, whose name you would recognize, anywhere in the country probably, all three of them had cases of irreversible blindness that changed their lives in a not good way, and those patients as well. So Christina Med Spa worldwide. That's it. We're going for it. I took your cadaver class and it was amazing. I was just saying we've added the retrobulbar injections to the cadaver class because after last night we're like, we have to let people know how to do this. We have to let people like at least experience and feel what it feels like. And the other thing you need to know is when you're using a cannula, you cannot penetrate the globe. You can't puncture the eye with a 25 gauge cannula. It's impossible. Try it. Try it in the cadaver class. You'll see. It's too dull. It's too smooth, and the eye itself is pretty firm and stiff. So I'm glad you enjoyed it. I plan on taking your cadaver class. Yeah, it's all about it. We're all about the cadaver. We're all about understanding anatomy before we understand injections. We're all about that. So let me talk a little bit about the topic of the evening. Unless you guys want to still ask questions about occlusions and retrobulbar injections, I'm sort of already like over it because I've been speaking about it all day. But I want to talk about biostimulators versus fillers. And the reason this came to be was about, 2 or 3 years ago, these two companies came to my office in Massachusetts, and they were sort of like, we have this idea for a new product. And they said, we've been working on this for a couple of years, actually for 10 years, and we're going to use silk, microparticles of silk, and we're going to mix them with cross-linked HA, and we're going to inject that into patients. Now, I remember silk from when I first started doing surgery. All of our sutures were made of silk. And silk was something that created kind of a lot of an inflammatory reaction. They were very expensive because silk is expensive. And we were using that for all of our sutures. Then it got replaced by other things that were in some ways better surgically than silk. But I still have silk sutures. I still use them occasionally. But they were talking about taking this in microparticles, combining them with a cross-linked HA, and injecting it as a filler. And the idea was that because silk is biostimulatory, like your body doesn't want it there and tries to break it down, that inflammatory reaction creates collagen production, right? Collagen synthesis. And so biostimulators, and the ones I'm going to mention, Radiesse, Belafil, Sculpture, now this new silk-based filler, are all devices that work differently, right? So if we have our traditional HA fillers, and there's 100 of them to name, then you just inject them. They're kind of inert. Your body's used to seeing them. It doesn't do anything. They just sit there. They just sit there, take up space, add volume to your face or wherever you've injected it, and they're lovely and wonderful, and we're really familiar with all that. I don't want to talk about HA fillers. But these other products are what I consider them sort of like fluoride toothpaste. Like if you look at Radiesse, Belafil, and this new biostimulator with silk in it, it's like if you have fluoride toothpaste, you never take a cadaver class once. You keep taking them because the more you know, the more you learn. We do cadaver dissections 8 times a year, and every time we do it, I learn more. I see things differently because you know what? Everyone teaches you anatomy in 2 dimensions. Anatomy's 3-dimensional. So if you don't understand the 3rd dimension, the depth of the anatomy, you might as well just pack it up. But that's what we specialize in. Where are you guys from? Anybody from far away? We've got a couple people from Brazil, Argentina, Marco Island, etc. Canary Islands as well. These biostimulators are like, I think fluoride toothpaste is how I describe them. You have paste, and then you have fluoride particles within the paste. And as you're brushing your teeth, these fluoride particles are liberated, and they do their stuff. Well, let's look at Radiesse for a second. Radiesse is calcium hydroxyapatite in a carrier of carboxymethylcellulose, which is essentially a sugar. So you inject Radiesse, this white pasty stuff, and the carrier, that carboxymethylcellulose, dissolves over the course of 8 to 12 weeks, and these little particles of calcium are liberated. Now, calcium is second cadaver class, definitely, please do. Please do. Love to see you there. These particles of calcium are liberated. They're stimulatory, they're inflammatory. The body starts reacting to them and making more collagen. So if you inject Radiesse, you fill the person up, and then over the next 8 or 10 or 12 weeks, it goes away. The particles of calcium are liberated, and they create collagen. These are what I call biostimulators, right? Belafil is the same way, but instead of carboxymethylcellulose, the carrier is collagen, bovine collagen from a cow, and it's been treated so that your body doesn't really react to it anymore. You don't really have to be tested for allergies like we did in the old days. But it has particles of PMMA, polymethylmethacrylate. Yes, take the class, keep taking it. I promise you, you'll keep learning more. Polymethylmethacrylate are like these little glass beads, right? And as opposed to the calcium particles in Radiesse, in Belafil, the PMMA particles never go away. So you have this chronic, constant, long-term collagen stimulation. And most people who use it a lot, who are very familiar with it, in fact, I've spoken to the scientists at Suniva, the company that makes Belafil, and they will tell you in all candor that it's permanent. So, permanency is a blessing, but it's also a curse, because if you do have an occlusion or do have an adverse event or do have a result that you or the patient doesn't like, what are you going to do about it? There's no way to reverse it. There's no way to get rid of it. There's no way to change it. So that's a big problem. But it is a biostimulator. The same thing happens. You inject the Belafil, the collagen dissolves in 8 to 12 weeks. The PMMA particles are released, and you get this inflammatory reaction and this matrix set up, and it stimulates collagen. This new product we're talking about, which is a silk-based filler, is kind of the same thing. It has an HA carrier. The HA, as you know, dissolves over some period of time based upon how long it's cross-linked and how hydrophilic it is and all that sort of stuff. And these little silk particles are sort of exposed to the macrophages and the other inflammatory cells, and they start producing collagen. The silk, according to this article, is degraded and eaten up by the macrophages and goes away. The other biostimulator, which I think in my mind is a pure biostimulator. Hey, where are you guys from? Anybody from far away? Anybody listening from, let's say, Spain or France or one of those countries? The Sculptra doesn't have a filler, doesn't have a carrier. It's a naked biostimulator, if you will. It's poly-L-lactic acid. It's made of some of the same materials we use in surgery for dissolving sutures, right? So they've taken these suture materials, so to speak, grind them up into microscopic particles, then you're injecting them into the patient's face. And because there's no carrier with it, you don't see any change right away. There's nothing filling it up. These particles are distributed in the face or wherever you're injecting them, and they start the same process of your body reacts to them and creates this inflammatory response, which creates collagen. Now, the nice thing about creating your New York, okay, New York's playing Boston tonight. Yankees, Red Sox, Claire Bear. I think the Sox should go. I think the Sox are going to win, but we'll see. We're off to a bad start with the Patriots, but we'll see. So, when you inject Sculptra, it takes a little bit of you to be a little bit of a daring. Hey, Linda Lieb, good to see you guys. Thanks for joining. Sophia, where are you guys from? Let me know. Ben, probably, can I still go? Okay. So we just need a cable for our laptop. We're about to die here. Anyway, I'll say this before I get out. So it takes a while for you to stimulate your body to make collagen. So it takes with Sculptra about 3 weeks before you see anything, right? So you have to tell the patient, I'm going to inject you with this product. You're not going to see any difference at all for at least 3 weeks, but trust me, it works. But the nice thing about it is when you produce your own collagen, it lasts for a long time. These studies, for example, with Sculptra have shown that if you do stimulate your own collagen, the studies go out almost 2.5 years, where 78% of people were still pretty happy. So, you can sort of say to people, these products take a while to work. They're kind of slow and gradual. You need multiple treatments, but once you get to your filled stage or your complete repair, it lasts for a long time. So that's the difference between biostimulators and fillers. I mean, some are a combination filler biostimulator, but the biostimulator part is the part that really creates the collagen synthesis that makes us, fuller. Hi, Linda Lieb. Good to see you guys. Hey, Mel from Connecticut, of course. That was I could have guessed that one. She was in our class last week and I think had a good time. She's going to sign up for our school in Connecticut. You missed the name of the product. It doesn't have the silk-based filler. So we talked about this new silk-based filler, which doesn't have a name yet, which Galderma is going to come out with shortly, or they just bought the rights to it. Radiesse, Bellafill, and Sculptra were the other 3 biostimulators. And I was trying to differentiate from fillers, which you inject, they immediately fill you up, mostly HA, and they don't do anything, and they just gradually dissolve. They just take up space, whereas the biostimulators, which is that, we use them all, and each one's a little bit different, and you have to make sure you have the right patient combined with the right product, with the right set of expectations. And as long, hey, Leanne, better late than never. Get a couple waves going there. Mel's back. So as long as you can understand the product yourself, understand how it works, understand what the normal time course would be, and most importantly, hey, Hatai, I can't believe you actually joined. This is great. And just explain what the expectations are for that product. So if you're injecting Sculptra, for example, see you tomorrow for surgery. Absolutely. Looking forward to it. You have to explain to them what the expectations are. If you're injecting Sculptra, you can't tell, hi, Hatai, you can't tell anyone that it's going to look different right away. You got to explain to them it's going to take a little patience. It's going to happen slowly over time. And we started this whole discussion because we were talking about a new filler that's coming out, really more of a biostimulator, Hatai, which is a combination of these small silk particles that are embedded in a matrix of HA that's cross-linked. And they came to my office 2 or 3 years ago to hear my thinking about it and see if I thought it would be a reasonable product. They showed me some of the studies, and I said, yeah, this is happening. Radiesse uses calcium hydroxylapatite, Bellafill uses PMMA, Sculptra uses polyl-lactic acid, and we know that silk is also stimulates collagen production, stimulates inflammation. So sure, it'll work. I think it'll work. So they're doing the studies now, and Galderma, I think, is going to buy the rights to it. It doesn't have a name yet. But be on the lookout for it. It'll probably take a few years to get to market. But anyway, that's where we are. We wrapped up the talk about the retrobulbar injections for blindness, and hopefully you'll never have to do that. We're putting that together as part of our new cadaver class. We keep getting new ideas, and as people ask us things, and Dr. Yolen was out from San Diego, and he was at our school last night, made a special stop from San Diego to help us and help my students, and we had a really nice high-level discussion. He's an eye doctor and ophthalmologist, so that's why we were talking about injections around the eyes and why an occlusion of the central retinal artery is different than any other injection in the face, because the rest of the face is pretty, is pretty tough and pretty robust, and you can, treat it really well and easily with hyaluronidase. But with the retina, because it's an extension of the brain, you've got maybe a max of 15 minutes before you have irreversible blindness. And as you probably know, there's never been a case of blindness from an HA filler that's been reversed. So food for thought. Anyway, thank you all for joining. If someone has, cost-wise, is there a big difference among the products? No, not really. They're all about the same. They all kind of work about the same. Whatever the soup du jour is or whatever the filler du jour is, they're all similar, right? You might have to look at the science to see which one creates the greatest degree of inflammation. But don't forget, every person's different, right? So if you give me Sculptra, it might work to some extent, and I give it to you or another person, it might not work as well, because our bodies react to inflammation differently and react to different products differently. So, thank goodness there's so many products to choose from. But can you touch on Vycross delayed reactions one day again? Yeah, I can talk about Vycross all day long. Similar ideas. I've done a whole video on that. If you look back in one of my, I don't even know how long ago, I've been doing this for a while. One of my videos, one of my Instagram lives, we did a whole thing on why people are having problems with Vycross, what it's about, how to fix it, what I think is going to happen. But yeah, it's an interesting concept. It's the problem's going away. I mean, I'm not seeing much of it anymore. And I think initially a lot of it was to do with contamination, people not using good clean, technique, the sterile technique, getting some contamination in those molecules, biofilms. These are all the kinds of things we talked about. But that's for a separate day. So today was occlusions. Hey Nina, thank you for joining. You'll have to watch this later because we're just about to finish, but thank you for joining. I'm here at 7 o'clock every Tuesday, sharp as a bell. Pedro's with me, feeding me questions if you guys have something interesting. But so take that with a grain of salt. Biostimulators versus fillers, retinal artery occlusions, retrobulbar injections, and why we should understand anatomy before we do anything. Have a good night, everyone. It's been a pleasure. It's been a lot of fun. Oh, one other thing I want to tell you. We just uploaded, we're starting a YouTube channel, and we're uploading a lot of videos. We just uploaded another one tonight at 7:30 for you or for your patients, really about how Botox works. So you can look at that, send it to your friends, like us on Instagram, and we'll see you next week. Be there, be square.